and breast cancer survivor. And the doctors are going to talk to us today about the Rise Up for Breast Cancer and Women's Health conference that was held in San Francisco in February of 2026 this year. It's our second year hosting this conference, and it's going really well. We just wanted to be able to provide the wisdom community with a recap of the highlights. It was a 3-day conference. And it was just such a wonderful event with a lot of energy behind it and a lot of really compelling, interesting information around um, breast cancer and also women's health more broadly. So we wanted to give everyone in our audience a chance to learn what went down at that conference. And we will hopefully have the conference in 2027. Let's see. Right now, we've got about 30 people on the call. We usually end up with um, around 50 attendees, so people may trickle in. Before we start, I'll just do some housekeeping. So we do want to hear from you. This is the format of these is meant to be community-based, and we want to hear your questions and comments. So we ask that you mute yourself when you're not speaking, but if you want to put some questions in the chat, we can interrupt the conversation to answer your questions. So put your questions in the chat, raise your hand on your Zoom if you want, or even just like raise your hand, and if we see you, we'll stop and be able to respond to you. The meeting will be recorded and shared. We post all of the recordings of our meetings on our YouTube channel. And so you can always go back and rewatch any of our wonderful community forum content. And a short meeting survey will pop up at the end of our meeting asking for your feedback. So it'll pop up onto your Zoom screen and you can just give some feedback and let us know how we're doing and let us know if there are any other topics that you would like to hear about in the future. Right. So, not sure if Laura has joined the call. Are you on yet, Laura? We can give her one more moment, or I can let Dr. McCreary take the stage and start the discussion, and Dr. Esserman will be joining us momentarily.
Yeah, I'm happy to. I'm sure she'll come. I guess I can briefly introduce myself. You all know Dr. Esserman, but I a long time ago actually worked with Laura at the breast care clinic before I went to medical school at UCSF. And have since become an OBGYN, and I've spent the last 5.5 years working in Shipwreck, New Mexico, and the Navajo Nation as an OBGYN, and I do a lot of primary care, a lot of sort of front lines OBGYN work. And then a little over a year ago, I was unexpectedly diagnosed with breast cancer myself. So I found myself back in the realm of breast cancer, although it's not without its overlaps from my own work. And so it's sort of been a unexpected but delightful reuniting of my former life and current life. And I'm excited to be involved and really I was grateful to attend the Rise Up conference, and so I'm excited to share with you guys today what happened, what we discussed. So I'll start because Laura is going to jump in. Let me see. Yeah, Laura will jump in with some details, but just to give you a little bit of background, the conference took place, like Stephanie said, it was the second annual conference. The first was held in the end of 2024, I believe, but it was held last month. And I think, someone correct me if I'm wrong, I think there were over 350 or so participants from all over the world, actually, which was really interesting. We heard from a lot of speakers, both from the US, but also internationally about work that is being done in the realm of breast cancer prevention. I'm going to skip this and come back to it when Laura is here, unless
I'm
she's.
here.
Oh, you're
I'm
here.
here.
Okay. Do you want to talk, Laura, about a little bit about how this conference came to be and what your vision was for it?
Yeah, we originally what really started a lot of this is I think Doug Yee and I and Judy Garber, I think, is that the next slide? This
Yeah.
is sort of this was the three of us were really very frustrated that with the passage of SB 8 in Texas, where women were being threatened and criminalized, and the law was changed to, criminalize abortion, that we felt as women's health professionals, we really shouldn't be having a meeting in Texas. And I think that made us start, then we tried to get the meeting moved. And then we thought, well, okay, we weren't going to go. And then the next thing we decided was, well, then we'll start a meeting. But we didn't want to have it be a competitor to San Antonio. We wanted to try and do something that was different and better, something that we hadn't done before. That's sort of what got us started down this road. But then if you go backwards, then what we thought was, wouldn't it be great if we could do something to really put prevention on the map, to really reduce that risk? Go back one slide now.
Mhm.
And so then the whole idea was, what if we set up an interdisciplinary conference, just reimagining breast cancer prevention treatment through the lens of women's health? And really trying to be out of the box thinking, what are all the conditions that women experience throughout their lifetime where they need some kind of hormonal intervention, whether it's cycle control or birth control, or if they have conditions like polycystic ovary syndrome, or if they have endometriosis, or they have fibroids, or, la-di-da. You know, um, and then hormone replacement, if you have early menopause or late menopause, and what if we really kind of rethought about this with an eye towards um, risk reduction? And and that's really how it started. And we did our first meeting in November of 2024, and it was really a huge success because we had, the OBGYNs don't really know that much about breast cancer. The medical oncologists don't know much about the hormone cycle really, and hormone replacement or all those things. We don't know much about any of that. It's not part of our curriculum. And no one really talks to each other. And then the internists are in between. And, how can we kind of think about this with, the overall healthcare needs of women? And so we built on that this year. Um, and we added Carol Fabian to our group of planners, and Diane Hadisian was our lead advocate who made sure that we put an advocate on every panel to make sure that you know, we really highlighted the experience that people have. It's not that, and it's not just that physicians, I mean, we talk to people all day long. We do this all the time. But I think the perspective that you have, I mean, a great example was on fibroids. It's like, it's a benign condition. It's not a benign condition. What it means, it's not a cancer, but it is completely disrupts your life if you have bad fibroids and you're bleeding all the time. And, you know, to make it really brought that home, it's just like, and people sort of saying from their perspective, looking at the issues, that people have a different perspective and different, maybe they would have different priorities. And from the perspective of physicians, we're always from the cancer side. It's like, oh, we want to make sure that we don't have the cancer come back. But, you know, it really depends. Well, what kind of cancer do you have? Did you have a life-threatening cancer? Did you not have a life-threatening cancer? Is it, you know, maybe it wasn't really that risky and you're suffering lots of other symptoms and it's not black and white. So that's where shared decision making comes in. And so it is that everyone's perspective matters, and most importantly, the people who we are, you know, taking care of, their perspective matters. And so it's just a good thing to remind everybody that, there's lots of ways to think about things, right? And so I think that has really enriched our meeting a lot. And you know, uh, I think when we started this meeting, we thought, well, this is a good idea, but we had no idea what a great idea it was. And I think this year everybody learned so much. It was really so much better than the first year. And next year is going to be even better than this year.
Mhm.
So Erin and I, well, Erin mostly put together a bunch of slides to help us start this conversation, kind of go through what we learned. We assuredly won't get through all of them, but we'll get through what we get through, and then we'll have another forum on the rest of it. But just to kind of catch you up, please, the forums are supposed to be informational. So it's hard for me to always be seeing who's putting comments in the chat. Um, so Stephanie's going to be monitoring the chat and interrupting us if you have questions as we go through. How's that sound? Is that good to everyone? Okay. All right, Erin, whatever's next.
I would like to just add here, you sort of already said this, but I've been to OB-GYN conferences and I've never seen patient advocates speak. I do think that they really added a special element. And I think a lot of people here in this forum, like this, you can play this role. I think that as a physician, you see the worst case scenarios that happen infrequently usually, but you apply that to every patient in front of you, I think. And I think oncologists, in my experience, often will do the same thing. And like Laura said, they sort of, to have that perspective of what it means to go home and live with the condition that you're living with is just a whole other realm. And so I really enjoyed hearing what these advocates had to share. So that was a really special part of this conference. Okay. Um, yeah. So we'll go through a little bit, just kind of the big ideas that were discussed, but I've also broken it down into some themes so we can kind of get into a little bit more of the specifics about some of the new things we learned about in the conference. We started off with a very exciting plenary session led by Dr. Esserman. So we'll maybe have her
So
summarize that a little
I,
bit.
I always like to start the conference with out of the box thinkers and getting people kind of out of their comfort zone and really trying to think about it. And, if we were trying to say, what is it going to take to make breast cancer prevention a routine part of care? Like, how are we going to overcome some of the big barriers? You know, the next session, which was about personalized screening, is going to show that breast cancer risk assessment could be made routine and we could identify high risk individuals, and so those are going to be people who are getting screened anyway. So if you have imaging biomarkers, great. We can start using that as a way to measure whether new drugs are working or new interventions are working. But then the cost of interventions to reduce risk has to be low because it has to apply across the board. And, the risk has to be low. They have to be safe. And probably the best thing is if they are dual purpose. So if you had fibroids, for example, taking something to reduce your fibroids and lower your risk, like an antiprogestin, like iloprosyl acetate, or actually mifepristone, which, by the way, that is the drug of choice for women in China. The only reason it's probably not, those two drugs aren't here, is because of politics and people worrying that you can use this for abortion, when in fact these drugs do have an important purpose, and getting rid of fibroids is not only important for tolerability, but guess what? Also for Black women who are at risk for triple negative breast cancers, if you have bad fibroids early on in your life under the age of 30, you're at higher risk for triple negative breast cancer. So that's kind of the idea. And one of the things we talked about is, there's a iloprosyl acetate is this drug that works, but it had this really rare idiosyncratic liver toxicity. And so the question is that just the population level of weird, it's less risky than atorvastatin, a very commonly, 100 million people using it. So why is it that we can't have a drug like that? Or are there new methods for looking at safety and kind of redoing that and fixing it anyway? We had one of my colleagues from um, the pharmacology department who's kind of rethinking about ways to sort of think about safety, medicinal chemistry, trying to do that. And um, Frank Gupton from VCU, Virginia Commonwealth University, who has really revolutionized the way drugs are made to make them simpler, cheaper, um, with less environmental impact. And like it's very expensive to make steroidal um, medication. So we have a whole project now where we're trying to think about, how can we do that? Because those things are really important. And then the last piece is, well, how do you make sure that it's easy to share your records and share imaging studies across hospitals in a way that's easy? All of these things have to be solved to make prevention routine. Um, and we just wanted to get people thinking about just because it's a problem doesn't mean it can't be solved. And so we had some pretty cool high level people working on solving those problems that, you know, you know, that will update for the next conference and probably either April or October of 2027. Anything else, Erin? Oh, actually, you said something that I thought was really important.
Mm.
You said most of your patients don't come in.
Oh, yeah. Yeah, Laura asked me to speak as a patient advocate on this panel, which was a lovely experience. And I ended up also, I feel like, putting on my patient advocate as a provider, as an outside breast cancer, the world of breast cancer provider. And I shared that, I see numerous patients a day, and they don't come in asking me, how can I reduce my risk of breast cancer? They come in for, as Laura mentioned earlier, a number of other women's health related conditions. And to be able, to offer them options that would also reduce their risk of breast cancer just seems like that's the opportunity, I think, um, to help intervene when this might not be on everyone's radar. And I shared a little bit about my own experience of receiving a breast cancer diagnosis. And the first thing I think so many patients will go to, as I did, is like, why did this happen? Not like existentially, but just like biologically, what went wrong? And then what could I have done, or could I have done something different to prevent it? And so it was interesting going through all of the topics that were kind of covered in Rise Up, and thinking a little bit about like, how could we do better? How could we offer things to our patients that are doable, that are, um, part of their lives, that isn't focused on breast cancer when they don't have a breast cancer diagnosis. Yeah, so yeah, it was an interesting session. It was a good way to start us off. And then, I don't know, Laura, do you want to run through a little bit? I guess I could run through
Yeah.
these, but people certainly
I
can.
can talk, I can talk a little bit about screening prevention. Obviously, this
Mhm.
is all the Wisdom Community Forum, right? So it's all about trying to do breast cancer screening in a smarter way and trying to encourage people to participate. And in fact, we're excited about the results, which I've shared on this forum already that we presented in December. And but by and large, yes, personalizing screening by starting with risk assessment first makes a ton of sense. And finding the very highest risk people first, which includes genetic testing, because if you happen to inherit those pathogenic variants or one like a BRCA1, 2, or one of those PALB2 or one of those genes, it's not common. It's maybe 2% of people in the population, but it's really important to know. There are things that you can do to prevent it. There are also things you can do to make sure you don't have a stage 2B cancer. For the people we had in that group that were screening every 6 months, no one had a stage 2B or higher cancer. So that's huge. And I then we also kind of thought, well, wow, why you could do this once. Why shouldn't you do it at 30? Because a third of the women with these mutations will get a bad cancer in their 30s. That's one of the things, I think most people know I run the I-SPY2 trial. And if screening were so perfect today, I wouldn't be able to run that trial because no one would be getting stage 2B cancers. But 70 to 80% of those people in I-SPY2, their cancers show up because people felt something or they had a symptom. They either were too young to be screened or the cancers were growing fast enough that they weren't found. So the idea of starting with risk-based screening and then trying to figure out how to improve it is really good. right? So to look specifically for the people who are at risk for fast-growing cancers, I think is important. And importantly, the looking at the many genes, polygenic risk, I think we've talked about that plenty of times on this forum, but that mix of genes that by themselves don't mean much, but together are predict risk. There is the signature for breast cancer really predicts hormone positive breast cancer, and that's probably the place where baby tamoxifen, not regular tamoxifen, but baby tamoxifen can reduce risk. So, knowing that I think is really important. There's a group from Denmark that was doing something similar, and they were looking to see whether people would accept doing less screening if they were in the lower risk group. And, they did. And like 90% of them were able to follow it. I think that's one of the things we didn't do particularly well in this country, but I think it's partly because, um, people are so sure that, screening every year starting at 40 is better. It's hard to move people off until you show that actually it's safer and it actually, the lower risk groups have many fewer cancers. So that's actually, or the rate is much lower. So it's actually very helpful.
Laura,
So
I think we have a question.
Yeah, we have a question from Tina Craig on the call, and she'd like to know if you would recommend genetic testing for all women.
I do. I strongly recommend it. And I actually particularly recommend it in the setting of a risk-based screening tools. If I thought running that trial was hard, trying to figure out how to implement all this is even harder. But we're starting to get some traction. We're trying because it's not doing this and doing Taracusic, because if you've been screened and you don't have genetic risk, you then don't want to apply the Taracusic, which is really through the lens of overemphasizing family history. So we also don't want to overestimate the risk because it brings many more people into the screening funnel. And then people wind up getting extra MRIs that they don't need, which have really high false positives. And so I think it's tricky. We are trying to figure out how to take what we've done and make that model more accessible for people. Um, so we're working on some demonstration projects. We're also working on trying to improve it and try and make it even better, because everybody knows that's what Wisdom 2.0 is. But there's a lot of interest around the world. I'm going to talk about it in Korea. I'm going to Brazil to talk about it. Going to Denmark, actually, that they're going to talk about it. Australia's trying to do something about it. I think I just got something from Germany. I'd like, I could probably go to someplace every week if I wanted. But I think there's a lot of interest, and I think it was just important to do the first trial to get people to know about it. And there's another big trial going on called MyPebs, which is in Europe. It's like 6 countries, including Israel, so Belgium, France, Italy, the UK, and I'm forgetting one.
Spain. It's
Spain. Yeah.
yeah. I was going to say I highlighted this a little bit because I think as someone who's not involved in wisdom as you are, I thought it was really interesting to hear about how there are different places around the world that are doing, and I think this audience would be curious to hear, that are doing similar trials to wisdom. And we had a great and all of them are doing some kind of stratification of patients into risk groups based on either both standardized tools and also the ones that we had heard from used polygenic risk scores. I believe Wisdom was the only one using the looking at known breast cancer genes. But we
Yeah,
have great.
the reason for that is that they did not, everyone's got something different, right? So that's the cool thing about collaborating. So the MyPeps people
Yeah.
felt like trying to do genetic testing, nobody would do it, and they would freak out over somebody knowing that information. But they also took their lowest risk group and aren't basically not screening them or doing one at the end of the study, which is at 4 years, which we could never do. We had to stay within the guidelines and couldn't do anything less than every 2 years. So they can learn from us and we can learn from them. Um, you know, And we compared the two studies, which I thought was super interesting.
Yep.
There are a lot more prior biopsies in the US, not surprising because we have lower thresholds for intervention, which I think we could learn from our European colleagues and do less. The rates of people using hormone replacement are something like 5% in the UK, and it's like 25 or 30% in the US, or maybe higher even, 50%. So it really shows practice variation. Um, and they asked in my pubs, how do you know that the genetic testing made a difference? But what we found was that the people who had mutations, who didn't know they had um, a mutation, like maybe 1% would be assigned to the every 6-month screening rates. And that's really where we cut down the finding of, larger tumors. So I think it really, really matters. And someone I think asked, whether it's covered by insurance. Not yet. We're working on it. We've applied to NCCN, the National Cancer Center Network group that sets guidelines, and the U.S. Preventive Task Force. Although they are kind of on hiatus, we're waiting to see if they're going to meet again. RFK has put some of their meetings on hold. I hope that won't be disbanded. That would really make me cry. Because if they say yes, risk-based screening is the way they did it in Wisdom is an acceptable alternative, then force of law, the genetic testing would have to be
Mhm.
covered. And interestingly, it makes screening overall less expensive because you're doing more for the people that need it and less for the people that don't. And, and we think that Wisdom would be less expensive overall. And interestingly, the one way demonstration projects might be trying to do this in the Medi-Cal population, or where someone's paying for the whole thing. Again, you can really try and find the people who really need it. I mean, people have lots of other things going on in their lives.
Mhm.
And, for the people who happen to have this high risk, you just don't want it to not, for people not to come to pass. But, 30% of women who were mutation carriers had no family history, and the women 40 and older. And in our current group, and the women in their 30s, 50% had no family risk. So our
Mhm.
current standard for looking to see whether you should do genetic testing is to look for family history, but that turns out not to be a very good test. So,
Mhm.
um,
Yeah, and I will say as a community provider, this is going off the conference a little bit, although I was really excited to see that there are many groups around the world working towards this model and this goal. But, as a community provider, you have a 20-minute visit with a patient to cover their cervical cancer screening and their breast cancer screening and their colorectal screening and their diabetes screening and STIs and birth control and whatever else they want to talk about. And so I am excited to hopefully see the results from Wisdom become translated into um, an algorithm for primary care providers to be able to offer risk-based personalized screening. So I think that it was encouraging to hear that there's many around the world working on this.
yeah, I
Yeah.
think it's going to change a lot. Yeah.
I don't know, Laura, do you want to go on and talk about some of the other things?
Well, I think, there are lots of new imaging techniques, and we talked about this. So I think that coming down the pike is, I would say, for breast MRI, you know, we don't have the capacity in this country to do an MRI on 50% of women, and 50% of women have dense breasts. And so there's somehow people are saying, well, that all those people should have MRIs. And that's just not true. And especially MRIs they're expensive and they have high false positives. We don't want to do that. It turns out that mammographic AI,
Mhm.
which is kind of a black box trying to figure out, okay, who really needs it? Maybe 10% of the women with dense breast tissue could use additional screening. And there are two things that mammographic AI does. One is it can see better than the human eye if there's something underlying. So who needs a contrast-based imaging? And it doesn't have to be MRI, it can also be contrast enhanced mammography. So I think it's important to understand that, and I think we've talked about this in this forum, is that ultrasound and mammograms use ionizing radiation or ultrasound waves to look to see if there's something different in the breast tissue that bounces back that sound wave and ultrasound or the ionizing radiation and mammograms. But contrast is looking at the vascular system, so what the blood vessels take up and wash out. So there are different and complementary techniques. So that is why if you're really high risk, you need to have a contrast image. I think using the same contrast they use for CTs for regular mammograms has been shown to be probably just as good as MRI. And I think lots of programs are starting to build that in, and I think that will make it much easier for high-risk women. So that's a good thing. There's a really something very cool, but we're a ways away from it. But that is, there's a couple of things that we are looking at. One is, can you do the MRI without the contrast, and can you use, again, mammographic AI to kind of simulate?
Mhm.
Um, and there's some cool, promising data, but it's a little ways away. But it is something that could be very, very, very cool in certain
I will
circumstances.
say I really honed in on this with my patient ears. And I actually, this is where I very much appreciated the advocate who spoke after this session. Um, I'm sure there's many on this forum who have had to go through a 45-minute breast MRI where you're prone and you've got an IV in your arm and it's loud and it's uncomfortable and you can't cough. And um, the to hear about this new technique where they're using AI to potentially avoid the need for contrast, which would make for faster MRIs, more comfortable MRIs. I just thought this kind of thing was very exciting from a patient's perspective, also, I would say.
Well, also but I think what it shows is what probably is achievable in the next year or so is fast MR, being able to do a 10-minute scan.
Mhm.
That alone would be hugely important. Um, I talked to Nola about it afterwards, and she said, "We're really, this is not next year.
Yeah,
This
that's
might be
fair.
5
That's
years."
fair. As long as
So I
it's
said,
something
"That's fair," but I
fair.
said, "Well, can we at least then work on the fast MR?" And
Yeah.
that's possible. And I
But
think
yeah.
that again, you know, we like to have it be as perfect or whatever, but
Mhm.
I think the fast MR is going to be, I think, really important. And just like the low dose MR, again, could that work? Again, what's exciting about that is that wouldn't take $1 million to seat an MR. It's a
Yeah.
much cheaper alternative. So,
And that
um,
that that was the other one that I chose to kind of highlight in these slides because again, coming working in a place where I am in a very rural setting and we don't have an MRI machine, or we once had one in our parking lot that they could not get up and running. Like it's hard to get patients MRI. So to have more availability where I mean it's really difficult for my patients to drive as far as they need sometimes for the MRI and
that's, I think, a great point, Erin.
yeah.
And
So
so that's where when I think, oh, really, are we going to go down to low field? But
but
this could
I
be.
when I heard this I was like this isn't I mean the accessibility for so much of this our country
I
this would
think that's an important point, and I think the fact that it's, reduced power consumption, we
yeah.
don't have to replenish the cryogens, and that for screening, this may be a much better alternative,
Mhm.
right? So, um, yeah, so I think it's good to see some of this work being done because that sort of gets back to the whole thing. What's going to make all this possible?
Mhm.
It's not what we can do at UCSF or at one of the Harvard hospitals or at Georgetown or, University of Alabama or San Diego, UCLA, blah, blah. That's not the majority of the country.
Mhm.
So we have to really be thinking about that.
Yeah, so it was exciting. There were some exciting new imaging um techniques that we learned about. There were also there was a lot on sort of new biomarkers. A lot of the science went above my head. One of the ones I thought was interesting. So biomarkers for everyone on here. These are other. They can include imaging, but other measurable indicators that you find either in blood or fluid or tissues that can represent a normal or disease biologic process. But these are crucial in developing drugs and in using as endpoints in clinical trials and in personalized medicine. So.
So
Um,
think about cholesterol,
mhm.
right? Where cholesterol's high, you get a cholesterol lowering agent. We can measure the cholesterol with the blood test, and it goes down. Or blood pressure. It doesn't have to be a blood test. Your blood pressure is high. You take an blood pressure medication. You can measure your blood pressure, and it goes down. Those are biomarkers, and those are biomarkers of risk that we can change. We call those modifiable uh, risk factors. So that's what
Yeah.
we're looking for.
And Laura, were there ones that you recall learning about in this at the conference that were exciting to you?
Well, I thought the microRNAs
No.
were
Yep.
good. I think those are exciting and thinking about, and also partly because they're cheap.
Mm.
They could be measured as cheaply uh, really as cheaply um, uh, as like a cholesterol. And I see, um, I'm looking at that little diagram that you sent me back, my own notes. And Martin Windwenger, the guy's working on, had also DNA methylation, which
Mm.
is, just, and are there easy ways to sort that out that's, is there evidence that, there's things that you inherit and then there are things that you're exposed to, um, that you can just get a few cells to try and figure out, they were looking at, cervical cells if someone's getting a pap smear to get some of that, or, you can do maybe a breast FNA, but, maybe we can do it off a spit test or a buccal swab, or, it's like rubbing the inside of your cheek and getting a little DNA. I mean, we have to have, if it's going to be something that's useful, we have to have easy ways of measuring it. Um, it's like, uh, in prostate cancer, they have PSA. It turns out that the level of PSA of 4 just turned out to be the wrong threshold. So it turns out if you have a PSA less than 1, basically you'll never get prostate cancer. And that's like 40 or 50% of the population. So it's a very common cancer in men. But if you can find half the population that doesn't need to be screened, that's fantastic, right? So we don't have that, but it would be great if we did, right? So I think that's, so I mean, again, when I think about the biomarkers, I think mammo AI is going to be really important. I think the background enhancement on MRI is important. I think it would be, who talked about adiponectin, the fat,
Mhm.
inflammatory fat. I thought that was, I thought, I don't know exactly how we measure that, but there are some of these tools that, and then I think that's actually an interesting tie into what came up later,
Mhm.
is it's not just your weight, but what kind of fat you have. You have brown fat or white fat, and this whole notion that we used to not be able to control what our weight is as much, but there's a whole class of drugs, that GLP-1 drugs, that can help you modify your weight and can actually help you modify the ratio of brown fat to white fat. And, those things can be something that we pay attention to. And it just so happens that there's so many things that are health promoting, that all line up in the same direction. Getting exercise, reducing your weight, either by yourself or with some help from one of these other medications, or getting yourself into, better ways that are making you healthier again, can really reduce your breast cancer risk. And so I think, yeah, that's actually, I think, exciting. And
Yeah. And we have, if we get to it this time, if not another time, there was whole sections on obesity and breast
yeah,
cancer risk, and then the GLP-1s. And I think the adiponectin came up in the context of, yeah, some of those studies where they were looking at the GLP-1s or other like intermittent caloric restriction, maybe, and low dose
oh yeah,
tamoxifen.
right. And that
Yeah,
that's
there
it
were,
was the like the fasting,
yeah,
the
yeah,
intermittent fasting.
yeah. Um,
But that sort of goes to environmental exposures,
It
right?
does.
So
I think that was actually the really exciting thing about this conference, and in trying to summarize it for everyone here, is that there was so much overlap in all the different sessions. Like we kept revisiting the same themes. So we had a few sessions related to environmental exposures and risk factors. There was some really interesting sessions from the Silent Spring Institute and other researchers about chemicals that may be implicated in pathways related to breast cancer. PFAS particularly got a lot of airtime, I think. And then we had some great lectures about the importance of the microbiome and fiber intake.
yeah, I think Carol Fabian said that she's never gonna
Drink
drink
out
from a
of a
plastic
plastic
water
water
bottle
bottle
again.
again. Yep. Yeah, yeah.
I'm
This
drinking my tea out of a regular cup.
Yep,
Okay.
yep. Yeah, so the Silent Spring Institute did share this resource with us to kind of like ways that you can walk through and reduce harmful chemicals in your own life. So you can, if hopefully this QR code still works, if you guys are interested in that. And then yeah, the PFAS got a lot of airtime as just being, we got a little bit of an interesting history of PFAS and how it sort of came to be, and then more and more um, concern for its implication in carcinogenesis. Although I think for breast cancer, there still needs to be more studies done to really to prove that causation there. But it was definitely generated some interesting conversation, and especially because they are in everything, as we all
Well,
learned.
it's interesting. My husband, before I became a full-time artist, and did, by the way, all the art for the
Mhm.
Rise Up for Breast Cancer, worked in environmental safety and toxics, was an environmental attorney, and worked in the state capitol for over a decade. And they talk. I used to be annoyed about it, but I now understand. So I think something that is different, and that is that there's the precautionary principle. Like you don't, this is, or having social, it's like the whole idea about black lung disease and people working in the coal mines. It took us a long time to agree that these silicate particles and all this exposure was bad for people, when in fact we really did have enough social evidence that it was a bad thing and that workers needed more protection. And so I think it's one of these things about we don't have the smoking gun and breast cancer and plastic chemicals, but you know, what we do know is that they don't belong in our body, and trying to reduce them and find other ways to you know uh, alternatives to plastics is a good thing. It's the precautionary principle, just in case. Are there other alternatives? And yes, there are. I think that's um and PFAS has been banned in Europe for a lot longer than it has in the US. And like they ban certain ones, but then they allow other ones. And anyway, so I mean, I think everyone got quite the earful.
Mhm.
Not, it's not, and I think there was actually Zero Breast Cancer here had a big movement to try and get rid of the some of the plastics in the IV tubing and the IV bags. Um, and they've done a good job of trying to get that. I mean, that there are alternatives that have much less plastic or parts. I think that, knowing that 98% of adults have levels of plastic that are like kind of unacceptable, you're like, whoa, okay.
Yeah, and it was exciting to hear about. We heard from I can't remember if she was a lawyer or just a lobbyist, but working, at the
Lobbyist.
government level, yeah, to try to implement some of these changes in more of a like systematic way, which
And
is
it
exciting.
takes it takes decades, and the industry people, are always trying to undermine the lobbyists to make them sound bad. But I think it's just a matter of is there a way we can you know, what if we can reduce that? How could we do that? Anyway, so that was it.
Yeah. Yeah, and then I lumped this in, but like we talked about before, it sort of came up in many of the sessions. But we heard a lot about researchers who work on the microbiome and the immense importance of that and establishing a healthy microbiome and its effects on inflammation, and as that pertains to whether it's cancer or obesity and body composition. Um,
So I would go back to say, even going back in that, you know, um, people have always been looking for, again, trying to find the smoking gun in diet and breast cancer. And, there are things that people who moved here from Japan, people in Japan have much lower rates of breast cancer. People who lived in Africa have lower risks of some kinds of breast cancers. They eat a lot of grasses and nuts and various things, but people who then move here then after they've been here 10 years, have the same risk of other people who live here. And so what is it? People thought maybe it was soy, they think something else. And I honestly think that the common denominator of all this is the microbiome. So it turns out your gut, you are outnumbered by bacteria 10 to 1. And that's and it, how food is digested all depends on these colonies of bacteria that live in your gut. And if you eat a high fiber diet, 30 to 40 grams of fiber a day, you have different colonies of bacteria, because it's a different type of bacteria that you need to break down fiber. And, just like they said, someone else's garbage is someone else's treasure. So it works like that. There's a whole ecosystem going on in your gut, that the first set of bacteria that, try and get rid of something like fiber, whatever they break it down into is what the next colony of bacteria then breaks down. So what you eat really determines what types of bacteria you have. And it's actually hard to measure all of these things. And the science is very complicated, but people are really trying to figure out how to understand that. There's some amazing work being done at MD Anderson, um, in melanoma, and they really are big. They've done some work showing that you can't go out and take a line probiotics and expect your gut bacteria to change. But if you really eat 30 to 40 grams of fiber a day, it changes. And if you have an immune-related cancer, having a high fiber diet makes a difference. And that's one of the things about antibiotics, is antibiotics can change your gut microbiome. So, you know, trying to cut down the overuse of antibiotics is important also. So again, all right, do we have the perfect data? We don't. But will it hurt you to eat a high fiber diet? It will not. It will be good for you. And eating 30, 40 grams of fiber a day can be kind of what GLP-1s do, that people don't realize that the gut actually is probably, other than your lymph nodes, the next most important immune organism in your organ system in your body. So it changes your immune health. So, we strongly recommend that people try to get 30 to 40 grams of fiber a day. And most Americans eat far less than that. An avocado, by the way, has 10 grams of fiber. A box of raspberries has 8 grams of fiber. I mean, it's easy to look up how much there is. And chia seeds actually have lots of fiber. So we are, um, there are lots of people now starting to do some research on this. It's hard to do and it's complicated, but I think it's super important. But in the meantime, there are easy things for people to do, and it will not hurt you. It will most assuredly improve your health. So, yeah, Katrine Whitson came and talking. By the way, she has this at UC Irvine. She teaches a class at UC Irvine, and she has um, a chef that gives classes on how to make things with fiber, and so it's a good thing.
Mhm.
Um,
Yeah, it was great. We all went home with recipe cards.
so it's
Uh,
good, and actually we did yeah, so yeah, we've done at Taste for the Cure, uh um tried to do tried to do a cooking class with some of that. So it's good.
Mhm.
Yeah.
Stephanie, should we allow time for questions or keep diving into some more of the?
I think we could fit one more small session. We've got about 10 minutes left.
Okay.
Okay. Someone asked me, I think, let's see, can you simulate contrast MRs? Oh, that is really just trying to compare people who have contrast MRs and try to use the non-contrast image to see whether you can train an algorithm to predict what it's going to look like. And it's tricky. I mean, it's a very exciting area of research, but it's not, nobody's doing this for clinical medicine yet. Anyway, but I think it's, that's what research is all about, right? Does everybody know where GLP-1s came from, by the way? Uh, very basic science project. Someone was trying to study Gila monsters and figure out how they
Mhm.
could survive in the desert and turn their metabolism down. It had nothing to do with this billion-dollar industry, but that's why science is important. Okay, Erin.
Well, on that theme, this might not be the shortest section, but we heard a lot actually throughout the sessions about how can we repurpose existing medications for breast cancer prevention or sort of focus on their tools, their sort of dual purpose utilization for breast cancer prevention. I picked out a few examples, but there were sort of many researchers who shared exciting work that is ongoing. As Laura kind of brought up in the beginning of the session today, one example of a very exciting drug that could serve this kind of role is something called ulipristal acetate. It's also known, I guess in this country, it's on the market as Ella, which is a form of emergency contraception. So we heard from Abby Liberty at OHSU, who is an OBGYN, who's a family planning specialist, a little and others actually about their work with ulipristal acetate. But Abby sort of reminded us of the how ulipristal acetate works as emergency contraception is that it essentially delays releasing your egg, but it is essentially an anti-progesterone, and therefore, we there is evidence that it could be certainly utilized in decreasing breast cancer risk. Abby did remind us that for women who are diagnosed with breast cancer and whose contraception, whose birth control options become very limited after they're diagnosed because many hormonal contraceptives utilize estrogen and progesterones. Um, Unlike those, Ella is still safe and very much a good option, at least for emergency contraception for individuals who have a history of breast cancer and are have been told not to use other forms of hormonal contraception because again, it is an anti-progesterone. But
I have a
Abby,
question for you, Erin.
yeah.
Do you think that we should consider having Abby for a community forum to speak
Oh, I
specifically about this? Because I thought it was fascinating and that it's
absolutely. I think
not
that,
well
and well, and
known.
so this, I
Great.
think
Yeah,
you,
it's a really good idea. Yeah.
yeah, I think you guys would love Abby. She's a very good speaker. She's very much interested in the intersection of OBGYN, women's healthcare, and breast cancer risk. I believe the Upside study is her study that she talked to us a little bit about, where she is, I mean, this is being done in other parts of the world, but Abby's looking at trying to use ulipristal acetate does like to see if that decreases breast density on mammography to see if radiologists can get better images and better like sort of is it better able to enhance the sort of sensitivity I think of mammography or the use
I thought that was so fascinating and important for women before women with dense breasts go to get
exactly.
a mammogram or if they are needing to get an MRI. Like what an important tool that is in the toolbox that's
Absolutely.
not being used. And I thought
Yeah.
about our wisdom community and that was something they'd probably want to know about.
Yeah, I think this would be I think it would be great to hear more from Abby about this. But yeah, because the idea is like, she's looking at women who have dense breasts on mammograms and then giving them ulipristal acetate and then repeating the mammograms and also MRI, as well as looking at some other biomarker levels and trying to see like, could this be a tool that could be used for women who have dense breasts to help with their imaging options? So that was really exciting. We also heard from Sasha Howell in the UK, who, along with others, is looking to see can this drug actually be used to reduce breast cancer risk. So he's, you know, looking at it in premenopausal women who are at increased risk for breast cancer. This drug, as Laura mentioned, is also has been shown to have use for treating uterine fibroids, which is a pretty unpleasant condition to have for a lot of women. It can cause a lot of problems. So anyway, he's trying to look and see if ulipristal acetate reduces breast cancer risk. And he, again, has identified a number of biomarkers to sort of look at to see if, including mammographic density, if it could reduce risk. Um,
And before you go on to any further
yeah.
slides, does anyone have any questions that we want to get answered in the next few minutes that we have together? Because we're going to have another community forum to review the rest of the slides that we didn't get to because this is such good information. So we don't want to have to rush through it. Does anyone have any questions?
I have a question. Hi, I have a question because I'm about to go for my every 2 years, I guess now, breast exams, and I don't understand what I'm supposed to ask for. Because I have been doing this for a while and I've got dense breasts. So I ask for MRI with contrast.
No, no, no,
What
no.
am I
You
asking
should
for?
not, you
Okay.
don't, most people do not need an MRI, and most people don't need ultrasound as additional imaging. It really depends on your risk. And depends on how dense your tissue is. Only if you have extremely dense breast tissue should that be considered. And it really depends on, that's why we're doing, what depends on your genetic testing results, and it depends on other factors that can be assessed pretty standardly.
Well, because of the past results, not that I've had breast cancer, even gotten to the zero thing, but they say, meaning the doctor and the insurance company actually agrees with them, which is unusual. It says, yes, I should have this. So you're saying now it's not indicated to do this? And I'm
Well, I
going on
don't,
April
I'm not,
1st.
I
So
can't, like
yeah,
in any other form, I can't tell you, I don't know enough about
yeah,
you to give you any kind of advice, but I think
right.
that we have often been wrong about our assessment, and we get people on the screening wheel and people use a 20% lifetime risk as a reason to get an MRI, which I think is
Mm,
way too low. And we actually
mm.
then subject people to all kinds of things and finding little stuff. And the next thing you know, you're down the road of getting more than you need. So I think it really depends, and I think you might want to talk about personalized risk management and, whether or not, you can say, I've read about the wisdom study. Is there something that we can do to sort of look at that rather to refine my risk? Maybe I don't need all this. Those are, I mean, or you could join the wisdom study and find out
I'm a
about your risk.
participant in the wisdom study, and I
Well,
got the
what is it?
email saying,
If, so I would follow that. And if that is recommending that you get an MRI, then in fact, that's a very strict standard.
okay, I'll go back and look at what they
You,
had said and
yes,
see.
you should do that. And then if you can't find it, please email Steph and we can look it up for you. So I mean,
Okay,
if
appreciate it.
you've had the most comprehensive risk assessment you can get is through the wisdom study, and it won't overdo it. And we have proven results now. So let's take a look at that. Let's start with that.
Thank you.
Okay, well, I think
Ah,
any other one last burning question? Um, uh, before we start, we've just scratched the
Brad?
tip of the iceberg here, so we have plenty more that we can get through, but it was really, I mean, I started last year with really, I'm gilocrystal acetate, any of the antiprogestins will for sure be risk reducing. And by the way, progesterone's in the causal pathway for breast density. So, and that's one of the reasons why I'm against progestins. Unless you really, really need it, there's some other reason that estrogen doesn't increase the risk for breast cancer and progesterones do, even modern ones. So if we can find a way to give people what they need without progesterone, that's a good thing. And there's a lot of people out there, recommending progesterone. We'll talk about it as we go through it. And, there's like 30, 40 years of data that's, if you're really low risk, it may not matter. But, if we can try not to do that, give progesterone, it's good. And the anti-progesterones really should work to reduce breast cancer risk. And I'm very excited about ways in which, especially for people with fibroids, what a cool way to reduce your risk and take care of the problem. So we're trying to figure out how to, I mean, there's lots more to the story.
I do
And
think that's a great example though, because as a OBGYN, progesterone is like what tamoxifen is to an oncologist. It's just what solves so many of our problems in women's health now. But I think that there's a call for better ways. Like we can find other things like the antiprogestins to help treat these conditions that, instead of increasing breast cancer risk would decrease it. So yeah, it's exciting. That's what the Rise Up conversations were about.
yeah,
So yeah, we can go through the rest later, but I hope.
yeah, I'm glad to see it. Like, and we're hoping to educate people. Yeah, this is one of the things, this is what started the whole Women's Health Initiative, was the finding that progesterone increases the risk, not decreases the risk. And that was like 35 years ago. And the person who did all that work to start it, we gave the Pioneer in Prevention Award to Malcolm Pike.
Mm,
And at 91, he's still very articulate and talking about it. So,
mhm.
okay. Well, we'll talk about it next month. If you guys are enjoying the conversation, we'll keep talking about it.
Thank you so much, everyone. I put my email in the chat. You can email me directly, or you can email info@wisdomstudy.org. And I hope you were able to fill out the feedback survey. Let us know how we're doing. Let us know additional topics. And we will plan to do an upcoming forum to finish the conversation on Rise Up. So we appreciate your time on this Monday and have a wonderful week.
Okay.